Okay, guys, and welcome. This is Robert here, and I'm going to be talking to you guys about one of the most common causes of low back pains that goes misdiagnosed, and it doesn't show up on an MRI or X-ray. So I know we have a lot of low back patients that come to the clinic, and they're in 6, 7, 8, 9 out of 10 pain, and they're saying like, "Hey, my back pain hurts," and they kind of give me a distribution. So like, forgive me, I'm going to throw some skin in here. Yep, so lower back. So basically what you see here is they'll kind of grab their hand and they'll say, hey, it's kind of located in this area. It kind of comes off to the side, and then they might pick the other side here, and they might have it going down there, maybe sometimes down the legs a little bit there. They say this side. So here's your spine. They might say that one of the sides here on the back. So there's your kind of your ribs coming across. They'll say that, hey, right in through here, it kind of feels like a vice grip, really crunching me down. When I try to bend down, touch my toes, it hurts. Leaning back really hurts like that. Sitting in a chair after I sit for a prolonged period of time, standing, that bothers me. So what we're talking about, we're not talking about a disc herniation. We're not talking about stenosis at this time. We're not talking about scoliosis, okay? There's a couple other diagnoses there that we're just not going to talk about today. So today's discussion is one of my personal favorites. The reason it's one of my personal favorites is because if we have, if we have, I'm going to use Fred to draw on. So if we have 20 patients that come in the clinic, okay, if we have 20 patients that come in with low back pain, okay, and it's not in the periphery, and sometimes it is down the periphery. What I mean by that is sometimes it's down the leg, sometimes it's down the leg, on the side, just around the glute. If we have 20 patients, usually anywhere between 12 to 14 fall into this category. So what I do first is this is what we do. We clear out this diagnosis. So as physical therapists, we're going to differential diagnose. We're going to say like, hey, let's make sure that the pelvis is aligned. The leg length discrepancy is an actual leg length discrepancy. There is one. A lot of times it's a false positive. Let's check out the back and let's kind of make sure things are where they need to be. And then I could start my clinical process of, okay, well, how old are you? When does it hurt? You're 45 years old. You had a mechanism injury. It hurts when you go down, touch your toes, and causes numbness, tingling down your leg. It's like, okay, well, we're probably dealing with a herniated disc. You do your clinical test, you find out. No different than stenosis. So stenosis, anybody over the age of like 65 and hurts with back bending extension, usually you could say with pretty much over 90% confidence that they're dealing with some kind of stenosis. So the diagnosis that we're going to be talking about right now is going to be called SI Joint Dysfunction. So some of you guys might see it as SIJD. It's kind of how it's spelled out there as an acronym. So basically what we're going to do is we're going to come down here into the lower back. I'm going to get rid of the skin here, and I'm going to expose the back side of the spine. So as you guys can see this here, and hopefully that's not, and there you go. It's up on the screen right now. So we're going to have L5, L4, L3, L2, L1. Those are the lumbar vertebrae. Okay, lumbar, low back, thoracic, mid back. You're going to have the 12th rib right here. Very important guy to kind of keep an eye on here. 12th ribs on both sides. You're going to have the iliac crest coming up here, and you're going to have a couple bones here at the pelvis. So you got this tailbone, your sacrum. You got your two pelvic bones out to the side. Now, I want you guys to kind of keep an eye right here, because this is what happens when you have SI joint dysfunction. Sometimes the pelvis gets a little bit out of alignment, and you're going to get a muscle, which is this guy right here, fade all the others, that's going to flare up. So that's called your quadratus lumborum. It's your QL muscle. It goes highly misdiagnosed. Now, sometimes people, PTs would, put you on the side. They dig in there and try to do a psoas release, try to do a QL release, and they're trying to release it, but it's not working. There's a reason for that. So what I'm going to do is, the other structure I want to show you guys, the psoas itself, like the hip flexor. People say, oh, we're going to stretch and get deep in the hip flexor. So if I bring this down a little bit here, and then I'm bringing some skin there, fade all the others. There's the hip flexor. It's deep. I mean, it's deep in the body, guys. So here, let me add some more muscles to it. Like, it is deep in the muscle. It is deep in the body there. And it's really hard. It's really hard to get down there. Palpate. You can palpate it. If you're good physical therapy, I know chiropractics and there's massage therapists, they could palpate and get in there and they could feel it. But as far as the belly of the muscle, like all the way down and through here, you're going to be dealing with like the GI system. You got digestive, you got respiratory. You're going to have to move a lot of stuff out of the way to get that deep in there. Okay. So what I want to show you guys is how to get that muscle relaxed and get some pressure off of it without having to do a lot of like deep manual therapy techniques. So what I'm going to do is going to pull up a video now. So Lauren is a past patient of ours. Lauren had a couple ACL injuries that she's been dealing with, and she's been coming off summer to just get some stuff going. So what she was doing is she was squatting down. She had a little deviation on her right leg where she had the surgery on. One would think glute medius weakness, one would think quad is what we're going to be working on. However, she's also coming in with a little bit of lower back pain, especially on the right-hand side. So I'm going to show you what this kind of looks like here. We're going to play the video here. Let me just mute it up. I'm going to bring Lauren up a little bit. Yeah, turn the volume down. And then I'm just going to kind of scroll this around. So what I'm going to do is Lauren's going to start squatting here. So her start position here looks good. So we're going to bring in so we're going to look at a couple different landmarks here. I'm looking at just a couple different landmarks for her to start. And then there's her ankle here, and then it kind of cuts off there, but I'm looking for like this nice straight line here coming down, and I'm looking for this nice straight line. Now, when I press play here, what you're going to see is she's going to come down, and then her knee from here kind of deviates in a little bit more than I would like it to. So she's deviating in and then coming back out. And then this is kind of like if she had her midline, we would say that that knee's deviating in towards the midline, which pushes the valgus moment on the knee. So that's kind of when the force is, that's the name of the force that we say on the knee. And then also most people would accompany that with glute medius weakness. Fair enough. So basically right there, coming down. A lot of squatters, when they're squatting overhead, they come down, they'll feel a pinch in their hip. They'll say, oh, my hip flexor's tight, and they'll try to get in there and start, grinding it down and try to really, crank on that thing. But, with that being said, it's really not the case. So I'm going to fast forward Lauren here. I'm going to put her on the table. One thing I love to do is I usually check leg length discrepancies here because they're always mostly false positives. What I mean by that is if there's any rotation in the pelvis and stuff like that, when you go to sit up and you're testing the leg length discrepancy, one might show longer than the other, but after you do a couple of things and then you retest and then it's even, it's a false positive to start. So, so that way, if someone just blindly threw a shoe lift in your shoe or something like that, you probably really want to go get it checked out by a professional, like a physical therapy professional, maybe even, like an orthopedic or chiropractor or somebody that's a little bit more trained in this stuff that they could, really tell if you have a true leg length discrepancy or not. And I hate to make you get x-rays, but if you really want to know, x-rays do a pretty good job of measuring leg length too, just because they have their tools and they can actually measure the length of the bones with pretty good accuracy. So Lauren's going to come up here. I checked her ASIS. So what I'm doing is here, I already checked her pelvis. Her pelvis is down on the right-hand side. It's rotated, and I'll show you what I mean by that here. So she's not getting that fire because the psoas is getting pinched off. The rectus femoris, which is right here, it's the quad muscle that's coming up here, is trying to help out because the rectus femoris does a little bit of hip flexion. So that's why she's able to do it. She's able to get a little bit of recruitment there, but at the same time, she's just still pretty weak. So as you saw the leg there dropping, we kind of just had a good laugh because it was, it was significantly weaker than the other side here. So what I want to show you guys here, I'm going to pause this video. I'm going to just kind of fast forward. I do a couple muscle energy techniques. I'm squeezing. She's pushing out. She's going to push into my shoulder here. She's going to push down, and then we're going to get to the point here, which is about right there. Check everything out. Great. And I'm going to play it from here. So you're going to feel that. You're going to hear that cavitation. I'm going to try to turn up the volume here. You're going to hear the cavitation on the inner lower back when I go to pull her leg over to try to release the SI and the lower lumbar spine. So here we go. Let's see if we can pull this over here. There's the little click. So you get the audible pop there. She's pulling up into my hand right now. So she's pulling up into my hand to do some glute medius activation here. And she's going to go over to the other hand side, and you'll feel one more. Hopefully you'll hear that one more click. There's a click there. So for lower SI joint, lower back pain, or excuse me, lower back, we're trying to loosen that up by doing an opening maneuver. Now what I want to do, and I'm going to stop here. So Lauren's going to do a technique now. So her pelvis here had a little bit of rotation down in relation to the left-hand side, and then it was shifted forward a little bit. So what this maneuver here is going to do, it's going to shift that little bit of maneuverment, and then she's going to basically be here. My hand's going to be underneath her feet, palpating the backside of her SI joint, and she's going to be pushing down into, here, let me get my little pen here. She's going to be pushing down into my thigh is right here. So she's going to be pushing there. I'm just palpating on the backside there. I'm going to recheck a couple things out and see where we're at. And we're going to retest to see if she gets that strength. The best way I could explain this is if you have a TV and then there's the pressure here coming down. So she's going to keep that leg straight here. She's going to go there, boom. So that no added pressure, no less pressure. You know, she's got it, and you could even hear the feedback from her. So I'll play some feedback from her. So you can hear some of the feedback she gives after we test this out. Good. Okay, so Lauren feels better with that. She's got a little bit more strength. That second maneuver we were talking about, she had a sacral, like it was like a torsion was coming up this way. I had her pushing down in order to pull that back. So now her pelvis is aligned. Low back, SI joint, L5, S1, that area has been released. And then what that's going to do is it's going to translate over to a standing position where she's going to drop down and do squats without deviation now. So let's see what that looks like. So she did a great job with that there. Really no movement in that knee. So basically when she came down that way, it looked awesome. So I'm going to switch apps over here. I'm going to come into an app here that we call, let me see if we can get this off the screen here. So this is 3D Medical. I really enjoy this map or this application. Because what it does is it allows me to kind of show patients what's going on versus just rambling and telling them. So what I look like for my back patients is there's my two landmarks that I was looking for on Lauren in relation to each other. The right one was down, the left one was kind of staying put there. So what that means is if you think of this thing as like a seesaw, okay, if you're going to be down in the front, you got to kind of be up in the back here. So when you come back here, this SI joint is going to be rotated up a little bit. That's going to put pressure here in a couple different areas, specifically your QL muscle. If you watch this area right here, okay, you're going to add a nerve through there. There's your sciatic nerve. So basically you have the sciatic nerve coming down. You're going to have this structure pushing on it. And then what I want to do is I'm going to add the piriformis in here. Piriformis, people think it's going to be pushing down the sciatic nerve because, you know, it's really tight. Well, the reason it's tight is because that rotation pulled it that way. You're going to do stretching exercises to stretch a stretched muscle, and then it's not going to be that much better. Okay, so that's my small little soapbox on the piriformis. Personally, I think you're just kind of stretching a stretched muscle. You have to clear the hips first, and then you can stretch it so you know that it's true tightness. Okay, so then what that is I'm going to come in the front here. There's your psoas, there's your hip flexor pushing on some of those nerves, getting shut off there. Now, one thing I do want to add, we said she was down in the front. The reason she was down in the front is because the rectus femoris would be really tight. So that when we palpated her rectus femoris, it was really super tight there. It was because that muscle does work hip flexion, tries to lift it up, but at the same time, it's not strong enough. So it's going to get a signal to fire. It's going to become really tight there in the hip, and it's going to start rotating that pelvis down a little bit more and more until we get that to shut off. So Lauren's treatment plan, realistically, is if you have this kind of distribution, and what kind of distribution are we talking about here? We're talking about low back pain that's on either side, coming across, okay? And then most people complain about pain kind of standing, switching positions early in the morning when they wake up, you know, and then it hurts kind of like down here, just about the knee. Could be a little bit of tightness back here where you sit, you know, back on the top of the hip. You could kind of feel like one leg's longer than the other, that kind of distribution. So basically what we're going to try to do here is we're going to release the quad, okay? On this side, I want to release the hamstring on the back side here. Okay, and then what I want to do is I want to come in through this area here, and I want to release that QL muscle this deep, and it's kind of like a cross pattern distribution, but that is 1, 2, 3 what we're going to try to release here in order to clear this person's low back pain. People that come in with knee injuries, people that come in with hip injuries, people that come in with ankle, knee, hip, back, lower back, I always check out the SI joint first in order to rule that out, just to make sure that we don't have to worry about any muscle imbalances. And then we start moving on to treating some of the different conditions. So hopefully you guys learned something from this video. Like I said, this is the #1 most misdiagnosed condition that we see here at the clinic. It's called SI joint dysfunction. And then hopefully that was it was a little lengthy, but it was a brief tutorial exactly what that looks like. So then that way, if you do have back pain, you could kind of make a note of this and understand that you would want to link up with a physical therapist who is certified in manual therapy, a lot of hands-on techniques, and they also do those grade 5 maneuvers where they can get things moving. Once again, my name is Robert, and I'm a physical therapist, and if you guys like our page, please subscribe so you guys can see more videos when we upload them. Thanks for watching, and enjoy.